Welcome, dear all. Today we are here for the DGF CME on infertility, which is organized on every 20th by DGF Infertility Group. So today, I don't think Madam will be joining with us because she is far away in USA at present. So Sir is there, Dr. Brigadier Sharma. He will be giving us the final verdict on everything which we are discussing today. So I welcome you all. First of all, I welcome Brigadier Sharma sir. He is Director HOD at Institute of Reproductive Medicine and IVF Center, Primus Super Specialty Hospital. Sir is the founder director of 2 ART centers which he has established in RR Hospital and Command Hospital, Pune. Sir is advisor at ART program of different medical colleges and private centers also, and he is former General Secretary of IFS and recipient of Jagdishwari Mishra Award from Foxy and Vishish Seva Medal by President of India. Our speakers for today are Dr. Shivani Sachdev and Dr. Jyoti Mallik. So, despite of much progress in ART, the quest for improving the success rate and clinical pregnancy rate and having minimal adverse effects goes on and on. Better ovulation protocols, and then our use of recombinant gonadotrophins, then ICSI, then freeze-all techniques, and a lot more. We have progressed in the field of IVF. Now even we can do the biopsy of the embryo also. So the field of ART has thus come a long way since first successful case. The future developments are expected to be equally dynamic. Dr. Shivani Sachdev is here today to put light on it. So her topic of discussion today is advances in ART. Let me introduce Dr. Shivani. Welcome, Dr. Jyoti Bali. If I have the CV of Dr. Shivani, yes, I can. She is Director of SCI Healthcare and Fellow Member of Imperial College, Founder Secretary, Delhi State Chapter of ISAR, Secretary, Delhi State Chapter of ISPAT at present, and General Secretary of INSTAR. She is ex-Vice President, Delhi Gynae Forum South, and Vice Chairperson of Women Director Wing, IMA South Delhi. So, Dr. Shivani, meanwhile you share the screen, I will introduce the speakers. Sorry, the experts of the session. Multi-screen share karwa. So, our experts are Dr. Tarini Taneja. I'll be reading the CV when she speaks. Dr. Seema Sehgal, Dr. Megha Mallik Dr. Archna Pathak, and Dr. Jyoti Bhasker.
Thank you very much, Poonam ma'am, for the wonderful introduction, and Sharda Jain ma'am and DGF Forum for this opportunity. This is a lecture that I take in the training program, and Dr. Sharda Jain is very clear that please talk only what you actually practice. So I have cut short the lecture because the lecture is quite long. So I will be skimming over just a few bullet points. So the ideal stimulation protocol, first of all, do we have one? As Dr. Poonam, you rightly mentioned, adequate number of oocytes, good quality, good morphokinetic score, high implantation potential, minimal side effects, minimal discomfort, and term healthy singleton pregnancy. Does this exist? We don't know. Let's see. Ovulation induction scenarios that we see in IVF are the following. Either it is a self cycle, or it is an egg donor, or we are doing a planned freezing, oocyte freezing for a social indication, or fertility preservation and malignancy. In IVF, such high-profile babies which have been born, like the Obama babies, the Ambani babies, Nicole Kidman's babies, and Sofia Vergara, the highest paid soap star in the US. All of them have used IVF, and somewhere that has increased the awareness, but maybe at the same time brought some complications also. Along with that, there are other celebrities who have spoken up openly about their fertility treatment for problems like breast cancer. So the types of ovarian stimulation that we do are basically three: either induction, superovulation, or controlled ovarian hyperstimulation. And whenever a patient walks into the clinic, in my mind, I always classify the patient as I'm expecting a normoresponder, where FSH less than 10, AFC 4 to 11, hyper-responder, which is PCO, or a poor responder, where FSH more than 10 or AFC less than or equal to 4. And always we remember the gate theory. This is the basis on which we do our practice, that when we do multiple ovulation, we open the gate wide. That means we give the stimulation for many, many days so that more and more follicles come in and go beyond the threshold. So why is this important? This huge study published in ASRM San Diego 2012, 231,815 cycle, landmark paper. Everybody should know this study. Why? Because this is widely even published in the non-medical New York Times and in the local media also. The birth rates peak with anywhere between 10 to 15 oocytes in fresh IVF cycles. After 15 oocytes, what happens to the birth rate? It remains stable, but the OHS's hyperstimulation increases unacceptably. But remember, this we are talking about fresh IVF cycles. So there is another concept in some people's mind that if there is a high response, maybe you get poor quality oocytes. Does that really happen? Absolutely not. Cumulative pregnancy rates are an indicator of IVF success, and if you have a high ovarian response, see the graph, it does not jeopardize the ongoing pregnancy rate. So remember, more eggs does not mean poor quality of eggs. And again, this study was done by Sankara, 2011, human reproduction. Again, that number, see where the graph folds on itself is after 15. So there seems to be this number of oocytes which is considered to be ideal for us to get the best success rate. And what is surprising is you see across the age group, 18 to 34, 35 to 37, 39, 40 and above, this number remains consistent to get the best success rate. And another landmark paper, 113,000 cycles, published by BMJ 2016. This should be an eye-opener. 57% of couples of all ages in the UK are childless even after undergoing 6 complete IVF cycles. So why was this paper published? This was published to tell people that many patients discontinue treatment after 1 or 2 failed cycles. Although the final prognosis, so if the patient doesn't give up and keeps persisting with the IVF, the final prognosis that the patient will have a live birth is promising. So there was another study now to see cumulative live birth, the total number of embryos transferred, means how many embryos you need to transfer to get 100% chance that you will have live birth. And this was a paper published 2019 by Hindavi and Zeng. On the left hand side, there's cumulative probability of live birth. So when the cumulative probability reaches 1, that means it is almost 100% that you will have a live birth. So in the age group, young age group, you see it is anywhere between 12 to 15 embryos that you reach the probability of almost 1. If you see more than 42 years, the last graph on the orange line, even at 12 to 15 embryos, the probability of live birth is only about 0.2. That means 22-23%. So what we understand is that we need at least 10 to 15 oocytes. So what to do? How to increase the number of... I think somebody's music is playing in between.
Dr. Jyoti Aggarwal, आप अपने को mute कर लो, please.
So how do we increase the number of oocytes to maximize this? If we have more oocytes, means we get more normal embryos. See this beautiful graph, PGT testing by array CGH. In egg donors, if you have 1 to 3 blastocysts or more than 10 blastocysts, the number of genetically normal embryos is consistent, 60-68%. In women who are more than 42 years, the number of genetically normal embryos is only about 13 to 14%. So what does that mean? That means that if your patient is less than 35, you need at least 6 cumulus oocyte complex, 5 mature egg, 4 fertilized oocyte, 2 blasts, out of which if you see 60% euploidy rate means 1 healthy embryo. For 39 to 40, we need 10 cumulus oocyte complexes. For 42 to 43, you need 16 cumulus oocyte complexes, technically speaking, to get you that 1 euploid blastocyst. So what is the first step to achieve this? First step is optimize your starting dose of gonadotropins. And how do you do that? You can use normograms. In normograms, the age AMH is plotted on the left, and on the right side, we have the FSH value, and where it intersects, that is your starting dose of FSH. So what are the drawbacks? Sometimes it is not so easy. In spite of using all these normograms and age criteria, there is unaccepted, suboptimal or low oocyte number. What does that mean? It means a low follicle to oocyte index, which means that it is less than or equal to 50%. So if you have 4 follicles, if you get 2 or less eggs, what can be the reason? First of all, your gonadotropin starting dose was low. Maybe the patient has a genetic mutation in her FSH gene, or environmental factor means your whole chain was not good. Asynchronous means there were follicles, but they were not all synchronized together in the pool. That is why. Or maybe last option is your trigger. Newer companies keep coming up with newer triggers and you feel, let me try, maybe it will improve things. But sometimes there may be some technical issues. So in this scenario, what do you do when we have unexpectedly low number of oocytes? We classify our patient into 4 groups. This is called as Poseidon. Patient-oriented strategies encompassing individualized oocyte number. This should be known by heart to each and every practicing fertility specialist. There are 4 groups in Poseidon. Group 1 is the young less than 35 adequate ovarian reserve. Group 2 is the one which is more than 35. Group 3, again less than 35, poor ovarian reserve. And group 4 is age also more than 35 and poor ovarian reserve. What are the 5 main strategies in Poseidon? Use recombinant FSH, increase the dose of your FSH, give recombinant LH, give DHEA before ovarian stimulation, and combine follicular and luteal phase stimulation. So the best practice in Poseidon group 1 and 2 is that increase the dose of recombinant FSH if you have less than expected eggs. If there are variants, you have to increase it up to 150. If there are no variants, then 50 to 75 unit. And remember this, maximum dose. I don't use FSH more than 300 because above 300, it is said the success rates are not going to improve. 300 is considered to be the highest dose. Consider dual stimulation and add LH. So how will you add LH? The ratio is 2:1 because at this ratio, the LH receptors are completely saturated. Adding more than 150 LH is absolutely of no benefit. Consider antagonist protocol, PGT testing, and single embryo transfer. Similarly, group 3, young age, less than 35, but you have poor prognosis, so you can even go for the long GnRH protocol. It is not mandatory that you do antagonist protocol. You can add androgens or you can add DHEA and do accumulation. So this is called as AccuVit. AccuVit means accumulation of vitrified oocytes and then frozen embryo transfer. And for the last group, about 35 means poor prognosis. Again, you can use GnRH protocol or you can use in the previous cycle contraceptive pill. I don't use that. I use estrogen estrogen to prime the patients, and then in the next month I do stimulation with 300 and I add LH also, I give androgens also, I give DHEA also, and if nothing works, I already tell the patient that if we don't get eggs of poor quality, then you should opt for oocyte donation. So now there are some new frontiers in this. What are the new frontiers? We used to think, we are so obsessed, should I start? I remember when I was training for IVF, I used to think day 2, day 3, day 5, which day to start. But now these new frontiers have come that there are waves of ovulation. They take place throughout the cycle and even when the woman is pregnant. So you can do something called dual stimulation. What does Poseidon mean by dual stimulation? That we give clomiphene or letrozole or FSH, give a trigger and do the oocyte retrieval. We don't aspirate, especially even if you're tempted, please leave those follicles which are less than 10 millimeters, because those follicles are the ones which are going to grow in the second phase of the cycle. So after a gap of 5 days, I start stimulation again and do a second oocyte. This is called as double stimulation, follicular and luteal phase, because there are waves of oocytes. Now there is a SWOT analysis. Basically what this shows is that it has strength, weakness, opportunity and threat. The problem is that the cost is high and there is freeze-all cycle, but otherwise the embryo quality is supposed to be good. There is a newer start which is called as a delayed start. What does this mean? That from cycle day 2, instead of starting gonadotropin, first start antagonist. Why? So that all the follicles are synchronized. If you see on day 2 scan, what is the purpose of day 2 scan? It is to see if the follicles are synchronized. If they are not synchronized, start antagonist, give it for 5 days and then start gonadotropin. So this is called as delayed start. You can also give estrogen in the previous luteal phase from day 21, which is called as priming, so as to synchronize all your follicles. There's another protocol called as andro IVF. What is andro IVF? We use testosterone gel 25 milligram every alternate day with letrozole daily for 30 days and HCG twice a week and cycle control with estrogen and progesterone. So in poor responders, this is something you can use in the previous cycle to optimize your success rate. Then corifoliatropin alpha, I'm sure you all know that it came with a big bang, that only a single dose will last for 8 days, but it never became popular because the success rates were not any better and people wanted to modify the dose, but they could not do it with corifoliatropin alpha. Genotyping in IVF. Nowadays, there is a lot of interest in this, that if we do the genetic testing, that is this FSH receptor is on chromosome number 2, P21, P16, 10 exons, 9 introns. And if you have the SIR variant, you need high dose of gonadotropin, or if you have ASN variant, then it is the best prognosis and high success rate. There's another protocol which is called as higher. What is higher protocol? Very simple. Sometimes we are giving the trigger and we wonder whether I should give trigger today or tomorrow. So remember, if your patient is poor responder, give it early. That is simply the higher, because there is less oxidative stress, less early luteinization, so that the quality of the oocyte is better. Then needle-free IVF, came with a big bang. New York, so many clinics open, even in London. Every acupuncturist is also talking about needle-free IVF. But what happened was that the success rates were so poor, it was abandoned. Needle-free, they use clomiphene citrate, nasal spray, egg collection under local, freeze, and then just with tablets and vaginal progesterone, they do embryo transfer, but poor success rate. So it was abandoned. Something which is expected in our market, Orilissa, orally acting GnRH antagonist, maybe we will get it, maybe not, let us wait and see. This is something Dr. Jyoti is going to talk about, PPOS protocol, where we are going to use progesterone from day 2 of the cycle to inhibit ovulation. So I will just skip this. She will talk about the advantages, disadvantages, and so on. I want to focus on this oocyte donation. When we are doing oocyte donation cycle, the patient is accepted. They just don't accept negative results. So difficult to counsel. So these are some small tips and tricks. Pre-treatment, try and do operative hysteroscopy. See on Doppler if the blood flow is abnormal, maybe you can give ecosprin, heparin. If there is some endocrine abnormality, specific treatment. During the treatment phase, if your endometrial growth is slower than what you expect, check estrogen value. You can change the dose, route of administration, or longer or shorter. protocol. And post embryo transfer, now newer concepts are coming to check progesterone and estrogen levels and to check prolactin, because these could be responsible for the failure. I started doing this, and in fact people say that you are giving only one kind of progesterone, not to give multiple kinds, but I am giving at least 2 different kinds of progesterone, because I do find that with one progesterone, in some patients, especially if they get their period very fast after egg collection, then they need multiple progesterone to support the luteal phase of cycle. I'm also using growth hormone injection, both for increasing endometrial thickness, where you can give it subcutaneous every day for 10 days, and also for stimulation phase for poor responders. Then PMOI has come. It is the association between progesterone to number of mature oocyte. It is more reliable than just the progesterone test before egg collection. And of course, luteal phase GnRH agonist. Luteal phase GnRH agonist in support with other agents like progesterone, estradiol, HCG are supposed to be very good for luteal phase support, where we are using 0.1 milligram subcutaneous every alternate day starting day 3 after embryo transfer, or you can start it day 5 after embryo transfer. Even in patients with previous failed IVF-ICSI cycle, there are so many different protocols for this. And it is a simple technique, not cost effective, and it's supposed to have better success rates. I'll skip to the IUI part. In IUI, GnRH analog is not found to be effective. So this is not something we can replicate in IUI. Again, letrozole. We did a whole conference on letrozole for women with patients of recurrent implantation failure. What do we do? This is something that I'm doing. Letrozole 5 milligram per day for 30 days in the previous cycle, because it reduces the volume of the endometrioma, reduces serum 125 and CA125, and result in higher pregnancy rates, especially in women with endometriosis or unexpected IVF failure. This is another technique that I'm doing for patients with previous failed IVF. In this, we are doing 10 intrauterine infusion, 3 ml only, ciprofloxacin, every 3 days, so over 30 days period. And this is just by using a used embryo transfer catheter or IUI catheter, small amount of Ciplox, especially where patients you are suspecting endometritis. So I send the biopsies for CD138 cells, or you just suspect endometritis but you are not getting TB positive. TB PCR is negative. So you can use this excellent. So many of patients negative have become positive after Ciplox. So I'm really thankful to the Greek researchers who came up with this. Then intrauterine HCG, I tried this. I didn't get very good success rate. Maybe Brigadier Sharma sir can enlighten us if we can give HCG before embryo transfer. And I will just skip this high dose letrozole, just fertility for breast cancer patients. Again, I'll skip it. Basically, it depends. You can start the stimulation anytime. Follicular phase, late follicular phase, after the LH, luteal phase. There are these protocols. So you just follow the protocol, when to start antagonist, when to start FSH, but you can start stimulation absolutely at any time. So the more we learn, more we realize, the less we know. And LH supplementation, especially in women about 35 years, it increases the local androgen which has reduced with age, but Cochrane review says no significant difference. And lastly, the concept of segmented IVF, which I'm following very almost 90% of my cycles, because there is, remember, 3 maternal deaths per 1 lakh. In India, if we are doing 2 lakh IVF cycles, 6 women are dying because of IVF. So we must switch on to something which is safer, which is the segmented IVF, which is just 3 things: that stimulation using antagonist, trigger for agonist, and freeze all the oocytes, so that the OHSS will reduce and almost become gone. In fact, CDC has described the number of elective FET cycle as dramatic, from 0 to more than 60,000 in a year. H-ray data is also shown. In fact, HFEA says for the first time the number of birth rate from frozen embryo surpassed that from fresh embryo cycle. And in the summary of US activity for 2016, CDC is unequivocal that the rate of pregnancy and live birth is higher after frozen transfer than after fresh. But ESHRE data still says that for normal responders, you can still do fresh transfer. But according to me, FET is definitely a more optimal strategy because we have had hyperstimulation in patients even with 5 oocytes retrieved. It is impossible to predict. So if it is at all possible, go for segmented IVF. Especially there is a change in the endocrine profile also, which has negative effect on implantation, placentation, with higher incidence of IUGR and low birth weight babies. And so to avoid OHSS, there is good evidence to use segmented IVF in hyperresponder, endometriosis, poor responder, but evidence not strong enough for all cycle, but it has an excellent safety profile. So it's widely used worldwide in modern management of IVF. Basically, you have to individualize the protocol. And lastly, path to shorten the time. Some patients will ask you, I want one child, when should I start planning? So this is the Delphi consensus. If you want a more than 90% chance of getting a one-child family, if IVF is acceptable to you, you can start when the female partner is less than 35, 2-child, 31 and 3-child, 28. But if IVF is not acceptable, then the ages are 32, 27 and 23 respectively. And this is the Delphi consensus. Again, this should be known by heart to all fertility specialists that patient age has no effect on live birth rate in oocyte donation. If the oocyte donor is aged between 18 to 34, cumulative live birth increases as number of eggs increases. Antagonist protocols are preferred. Agonist trigger is preferred. Dual stimulation. And also the patients will ask if they have had fresh IVF, whether they should do embryo transfer immediately next cycle or you want to take a rest of one cycle. So Delphi says immediate frozen transfer after failed fresh is recommended for good success rates. PGTA testing with comprehensive chromosomal screening is recommended, and women less than 40 years, maximum 6 single EP. So thank you everybody. I hope I am in time to give you some insights into what I thought was relevant in my practice especially. Thank you.
Dr. Poonam, you're muted. You're muted in the spaceship.
Dr. Poonam, you are muted. Unmute kijiye.
That was wonderful talk. The insight you have given was very, it's kind of eye-opener. That is why Madam appreciates this talk so much. So now we will be coming for expert comments. Dr. Tarini, are you there? Dr. Tarini, are you there? I think she has left. So
yeah.
Let me call Dr. Seema. Dr. Seema? Dr. Seema Sehgal, ma'am, are you there? Yes, I just saw her. She was there.
Yeah, she's there.
But she is not answering. Dr. Megha?
Hello, Dr. Poonam, am I audible?
Yes.
Yeah.
Welcome, Dr. Tarini, welcome. So just
first of all, thank you so much.
Tarini, she is currently chairperson of ISAR, Delhi State, and President, OBG Societies, UP State. So your expert comments, Dr. Tarini, you are audible.
Dr. Poonam, first of all, many thanks and gratitude to Sharda ma'am for giving the opportunity, and to you, many thanks for putting your efforts to connect with me. The lecture was Dr. Shivani and was really mesmerizing, eye-opening. She is really expert. She is really queen, as we always used to say, queen of surrogacy. So what I must say, there are almost explosive development in the ART with the goal to give the better outcome of pregnancy to the couple. But the poor responder is really a dilemma, as Dr. Shivani already explained. From the Bologna criteria, we have come to Poseidon criteria just to classify the low response in the patient so that we can counsel better and tailor the stimulation protocol accordingly. So what is the problem is coming, though there are so much development in the stimulation protocol. to prevent the OHHS, plus also in the embryology to get the better oocyte. There is the PGS has come and PGT has come, so many things, and so many advanced techniques has come, embryoscope and everything that is not affordable in a routine. But Dr. Shivani has given so many, protocol. So main thing is problem we are getting the genetic problem. In the genetic, when there is in the poor responders, because there are the few receptors on the granulosa cells, because the cycles are shorter because of the poor arboreal reserve. Or moreover, I have read few papers that the presence of auto-antibody against granulosa cells. So how come we can overcome all these problems? Let's see in the future. The future is also the gametes from the stem cells, gamete from the skin cells. So there are so many advances. I think in the future, nobody will be childless, and those so many, protocols. But what I do in the poor responder, I really prime the patient with the estrogen, and then we are giving the oral. Then I give the dual protocol with the clomiphene and the letrozole. Or still, many times I try the natural cycle for the poor responders with the adjuvants. And also, if I am doing with the gonadotrophins, so I use the anticycles. So thank you so much. There's so much to speak, but time is less. So thank you for giving the opportunity. And my greetings and namaskar to Dr. R.K. Sharma. He is also my mentor. I would like to listen her final comment, expert comment. So thank you so much.
Now I invite Dr. Megha ma'am. She is consultant at Baby IVF Center, Rajouri Garden, and she is Joint Secretary of DGF West. Dr. Megha Mallik. Dr. Megha?
हाँ ये चलेगा अच्छा चलेगा ठीक है अब इधर देखा तो भेज दे साफ कर
Dr. Tarini, please mute.
Hello. Am I audible, ma'am, now?
Yes, you are audible.
Yeah, thank you, Shivani ma'am. It was wonderful lecture. I think you covered all the points, very relevant points in a day-to-day practice. And especially, I would like to add that the cetrelix, which you have added, antagonist in the initial 3 to 4 days, that is very patient-friendly. And we have also got very good results in those patients. Like in poor responder patients, or we have to time the cycle and the equal cohort of the oocytes, the response is very good. I have used it and I'm trying to increase it more in my day-to-day practice. So that protocol is very patient-friendly and good for the doctors also in terms of response. And also the other, I think the latest protocol should be more patient-friendly, which we have also highlighted. It should be more comfortable to the patient with lesser side effects when patient is more comfortable to take the latest protocols, and the compliance of the patient is also more good because they get tired after so many stimulations, especially the poor responders. So these latest protocols which you have highlighted are very important, and the rest all I think is you have covered everything. And I just wanted to ask, ma'am, do you use latest combination of recombinant LH and FSH, pargovirus, which is there in the practice? Anything you have felt that the quality of embryos is better with that? I have used in few patients, but just few patients cannot lead to the result. So any experience yours or Sharma sir's?
We'll be asking Dr. Sharma all the questions later on.
Yeah, I got some samples for that, and as you said, I have hardly used for 2 patients, so really I cannot give so much opinion on that. I think we will have to look at the Brigadier Sharma sir. आप ही बताइए.
Yeah, thank you very much. I think you've given a very wonderful lecture, and you have evoked a lot of questions, and maybe you've given good answers also to many of the questions. See, what is happening now is that somehow we are reaching at a level where every even 0.1% success, will better than the previous one will be considered as an achievement. Because earlier, every decades we are having the pregnancy rate increased by 5%, 10%, But now we have come at a stage where the increase per year or per 5 years will not be more than say 1%. So all these small things, because we are going into the details of how the genetics is working and how the response of the patient is working, the polymorphism in the genes and all. So we all studying into that so that we can increase slightly the success rate. But do not expect there is going to be a huge change in the success rate with all these things. But yes, definitely it will improve, and that is how it is going to be. And the first question was, the HCG, in a patient's intrauterine installation to increase the pregnancy rate. Yes, there have been, studies where they found receptors of HCG in the endometrium. So if that be so, the HCG has got some role, at the time for implantation. So when should you, inject HCG? Now, most of us, if you are doing the fresh embryo transfer, we will be doing blastocyst. So on the day of the ovum pickup only, the patient is already under anesthesia. So that is the time one should inject the HCG in the uterus. So that even if, if there is a small mechanical injury, even if you have used the softest of the catheter, there will be some amount of injury to the endometrium. And that would heal. And maybe that growth factors also which are, being produced for healing, plus your HCG, hypothetically, either of them work together to increase the pregnancy rate. So the timing has to be there. It should not be done on the day of the embryo transfer or 1 or 2 days before. It should be done, we should give time, for the HCG to attend those receptors, and also if there's a mechanical injury, so that should also heal. Because if there is a blood in the uterine cavity, the complement which is there in the blood can affect the implantation. So at least 4 to 5 days before you do the embryo transfer, you should do the HCG. Secondly, for synchronizing the cohort, you will be giving antagonist. Now this antagonist, when it is given, so we know that after 4 to 5 days, your LH and E2 is going to go very down. Possibly, instead of FSH, you may have to give the FSH as
Dr. Seema, I think you have got 2 mobiles there on.
a response. Otherwise, these patients are downregulated and you may not get the response in these patients. Now, regarding this parvovirus which is there, this is more useful, in the patient where you, in the previous cycles, like the patient has come to you, she has visited many other centers, and she otherwise had a good enteral count, but her response was poor. So under those conditions, when you are giving a recombinant FSH-LH combination, possibly in that group of patient, it will do better than in all the patients. So a patient who is having good enteral count and previous history of poor response, so possibly, there the receptor polymorphism is there. So the urinary products or even the recombinant FSH you are giving alone may not work as much as you add recombinant LH as well along with that. So in that subgroup of patients, parvovirus may do a better job than your other combinations. And regarding this, doing the pre-genetic testing and all, it is good, to answer many questions to the patients, but it does not improve the pregnancy rate as such. If you see many papers, it doesn't increase the pregnancy rate, it just increases the cost. And especially if there's a high-strung patient who really wants to know why, I want to be 100% sure that I am pregnant. Nobody can give you 100% surety, but at least if we have 10 good embryos, then maybe we can do the PGT and we can tell them, okay, out of this only 3 are good and we are transferring those, expecting to have a better pregnancy rate, but still it will not be 100%. So keeping that thing in mind, I think the new advances are there, and every time we will look the same problem from different angles. But at the same time, as a condition, we should not expect dramatic 10% increase in the pregnancy rate with any new advancement. It may be 0.1, 0.2%. As advancements have reached, I feel now at a plateau level in the field of ART.
Thank you, sir. Thank you so much. Now I invite Dr. Archna Pathak. She is senior consultant at MKW Hospital and it's my baby IVF center. She is founder, secretary DGF West and presently president of DGF West. Dr. Archna?
Thank you,
Yes,
Dr.
she is there.
I must congratulate Dr. Shivani for an excellent talk. I think she was wonderful, quoting so many studies. And this was use of Ciplox I'm hearing for the first time. This paper really is an eye-opener in case of endometritis, its use. I think, Dr. Shivani, premature ovarian insufficiency and poor responders remain a real challenge for all of us still. And I would like to know what should you do if a patient who's into premature ovarian insufficiency with high FSH, LH, low E2, she still insists on having her own oocytes. What do you do in such a scenario? What best can you offer her?
You can offer her PRP or bone marrow cells intra-ovarian or in the ovarian blood vessels. And after that, you can just give clomiphene, letrozole or low-dose HMG and do multiple cycles. Maybe in some cycles she may respond. She may need 6 months, 1 year to respond.
Okay. Thank you. Thank you so much.
Here I can ask, can I ask one thing, Dr. Shivani? You said don't use more than 300, but presently in our center we are using even 450 also. So I would like to know how many days of stimulation with 300 with you, how do you
No,
go
ma'am, poor responders, so I use low dose. I don't even use, sometimes I use only 150 or you can even use just clomiphene and letrozole. The egg
How many
quality
days of stimulation?
Stimulation, 14 days, 18 days, 20 days, it can take time. So it is time consuming. But it is said that more than 300 FSH, the success rate is not high. I remember 2001, 2002, when I was working in Mumbai, more than 20 years ago, 900, pura 900 we used to give in 1 day, full pen to a patient per day. Because we used to think, those were the days, then it stopped completely, it came down to 600. Now from 600 it's come down to even more.
So it doesn't make any difference with the recruitment of number of follicles?
Not one extra pregnancy you will get. So it doesn't improve the pregnancy rate. Others, Dr. Jyoti Bali may have some, Dr. Aruna may have
I'm
some.
coming to Dr. Jyoti Bali now. So Dr. Jyoti Bali, please, your expert comment.
it was a
Dr.
wonderful
Jyoti Bali
lecture.
is the Director, Baby Soon Fertility and IVF Center.
It was a wonderful lecture, Shivani, but I think I do agree we are on the same page that Cochrane reviews and other studies have said that more than 300 does not benefit any better except increasing the cost. We are neither going to gain the quality of the oocytes or the number of the oocytes by just going on increasing the dose. So 300 is what even I practice, and maybe as she said that we can do oocyte pooling if required for poor responders, or take up milder protocols rather than taking these heavy duty protocols where you go to 450 or 600. The option should be to try the softer protocols for these patients, and not going more than 300 is also my take, and I'm on the same page as Shivani.
Okay, thank you so much. Now I come
Shivani,
to
any
Dr.
experience with progestins instead of using antagonists for first 4 days or 5 days?
I got very poor embryos. Progesterone was very attractive for the cost, but really I don't know, embryo quality is a big concern.
So now I come to Dr. Jyoti Bhasker. She is presently working as senior consultant at Cloud9 Hospital, Padparganj, and she is president of Delhi Gynae Forum East and secretary of Delhi chapter of IMS. So your comments, Dr. Jyoti?
Yeah, thank you very much. And it's nice to be the last person to make a comment, so I don't need to say much because everyone has already put on much. So I'm going to speak more from the point of view of everyone who practices infertility and not IVF. So I feel, as far as the normal responders are concerned, or as far as PCOS is concerned, we all have really mastered it. We have got very good results. But the problem actually lies in two areas. That's a poor ovarian reserve and the recurrent implantation failures. And as Dr. Sharma rightly said, this is the area we are really working on. And this is the area we may not get very great results, but for each clinic, if out of 5 we are able to get one person to get pregnant, I think that's a good result as far as that clinic is concerned. one thing that I need to say over here is that we are finding more and more young girls who are less than 35 and who have got a low ovarian reserve. So over here, as infertility specialists, we all need to be very cautious. We keep giving these particular women more and more clomiphene, this and that. But we need to realize that we need to move to IVF, and we really need to move to the better protocols. That is not just giving them FSH, theek hai, ho jayega, aisa nahi hoga, because we're going to waste their eggs. We need to move on to the much newer protocols. And as far as the many that Dr. Shivani has said, that we have so many protocols on the Poseidon categories that we're talking of, how do we know which is the best? And I think that is only by experience. So like I work with Dr. Aruna, and Dr. Aruna has been in the last few, she keeps telling me this, if she's over here, that more and more we are getting patients with poor ovarian reserve. I really don't know what to do. So she's been using, we have been using recombinant LH also, we've been using dual stimulation also, we have been using PRPs, this also, GCSF also, everything that's possible we are trying, but definitely it's once we experience which gives us the confidence. Yes, it works. It's good to hear the evidence, but
Dr. Tarini, please mute. Dr. Tarini, please.
With recombinant LH, yes, we have recently done about 5 patients of which we did manage to get 3 of them with good quality, and they did conceive. So it was a good result, but we need to see further how it tends to work out. So this is one area I feel that as gynecologists we need to pick up these patients, send them to IVF specialists. So that
Dr. Tarini, please mute.
Do better. I think I'll stop. Thank you.
So, Dr. Sharma, anything else you want to say on this topic? Should we move ahead? Sir, you are mute. Sir, you are on mute.
I said it has been excellently dealt by Dr. Shivani and by all the experts. And we carry home message is that we have to, tailor-make the protocol according to the patient's requirement and also the financial control we have.
और मैंने तो वीडियो ले ली थी उसमें से फिर फोटो निकाला नहीं उसमें से फोटो निकाले स्क्रीनशॉट
Dr. Tarini, please mute yourself.
So we have to be realistic with the patient and tell them, okay, we are doing this thing, but this is the likely to be your result as well. So I think keeping everything in mind, if we have selected the right protocol and if we have counseled the patient properly, we can, achieve the results.
Thank you, sir. So now we'll be moving to our second talk. Dr.